Good morning, everyone. Very excited to give this talk. I work in this beautiful place. So is so many in this room. King Faisal Specialist Hospital in Riyadh. This is how it looks at night. That's why we like to stay late, and work late to see this view, I guess. These are my disclosures. Talk of view. I'll be first touching on the current therapeutic landscape in diffuse large B-cell. Then we'll move on to speak about the clinical data for commercially available CAR-T in the third line and second line setting, and we will conclude with the CAR-T challenges and other competing therapeutic options. For 18 years, plus or minus, the only thing that we had is rituximab and diffuse large B-cell lymphoma, different formulations, until Axi-cell was approved in the third line setting, followed very shortly with Tisa-cell, and then we got some antibodies, Pola-BR for the relapse refractory after autologous stem cell transplant. So there was a drought, and then we had several agents. However, in the last 3 years, we've had the therapeutic advancement in diffuse large B-cell ramped up and accelerated quite a bit. We've had several antibody-based therapy, including Bayer antibodies like tafasitamab, which is a CD19 antibody, loncastuximab, which is a antibody drug conjugate, as well as other less favorable options like selinexor. We also had other CAR-Ts approved in the relapse refractory, and we had some encouraging data moving these CAR-Ts to the second line, and then the birth of a very highly anticipated class of drugs, which is bispecific antibodies, and the rightmost, glofitamab and epcoritamab. Polatuzumab was able to make it to the first line setting. All of these changes happened in the past 3 years. We don't know what's going to happen in the next 3 years, but we'll stay tuned. Okay, so currently we have 6 CAR-T therapies that approved, FDA approved, all of them actually for B-cell lymphoproliferative disorders. We have 2 products approved for multiple myeloma, 2 products for ALL, and then we have 5 indications for diffuse large B-cell, 2 in the second line setting, and then 3 in the third line setting. So commercial CAR-T is also coming to B-cell lymphomas very quietly, very rapidly, and moving on in therapy and moving on in the line of therapy from third to second. And we don't know, maybe the first, with the upcoming Zuma 23 and what so. Okay, so before we dive in the clinical data for the CAR-T, commercial CAR-Ts, let's step back and take a look at the outcomes of diffuse large B-cell prior to the CAR-T and bispecific era. It was just simplified, in a very concrete way. If you took 300 patients, 200 patients will be cured with R-CHOP, 100 patients will relapse. Out of the 100 patients, only 50 will be transplant eligible. Out of the 50 who are transplant eligible, only 25 will respond to salvage chemotherapy, and only 10 of these patients, 10 patients of those will actually be cured. So only 10% of patients who are relapse refractory will make it. That's prior to the bispecific and CAR-T era. So how did CAR-T transform the treatment paradigm in large B-cell lymphoma? We'll go through the data. First, it emerged through the third line setting. We had 3 phase 2 trials for 3 commercially available CAR-Ts. First of which is the Axi-cell, which is it was a phase 2 trial, the Zuma 1 trial, and after a medium follow-up of this is an extended follow-up that was recently published after a 5-year follow-up. The OS rate, the overall survival rate is 42%. The 5-year disease-specific survival is 51%. We were worried about the duration of response, and after 5 years, we can say that the median duration of CR is 62 months, and it looks like there is a flat line there. So are we experiencing cure? You know, everybody is shy to say that, but probably yes, you know, with the 5-year survival data from ZUMA-1. The second product is Tisacel through the phase 2 trial GILEAD, and after a median follow-up of 3 years, the overall response rate was 52%, and the CR rates was 39%. Just to bring to your attention that the CR rate with Axicel was 58%, but we cannot really do cross-trial comparisons. So after a median follow-up of 40 months, the median OS was 11 months. Median duration of CR actually is pretty durable, and we do see a flat line and a very long tail. Does that mean that we see a cure with Tisacel? Maybe we were waiting eagerly for the longer follow-up. We just have the 3-year follow-up. The third product in the third line setting is Lisusel, which came late in 2021, was approved. And after a median follow-up, the shortest follow-up that we have is 18 months, actually, among the other products. The overall response rate was 73%, CR rates was 53%, and the median OS was 21. A median duration of CR was not reached, but we'll still see, you know, we're eagerly waiting for a follow-up in the maybe next ASH. Okay, with the excitement that the CAR-T created in the third line setting, it was inevitable to move these to the second line. So there was 3 simultaneously put together phase 3 trials that took place almost the same time. The first of which is the ZUMA-7. Axicel was in a randomized phase 3 trial, was compared to standard of care, which was salvage chemotherapy followed by autologous stem cell transplant in high-risk relapses, which is relapsing less than 12 months of initial chemoimmunotherapy or primary refractory disease. The median, the primary endpoint was actually event-free survival. So the estimated 24 months EFS after a follow-up of almost 2 years was 8.3 months, as opposed to 2 months in the standard of care arm. Median duration of response was 26 months for Axicel compared to 8.9 months for the standard of care. There was a pre-planned subgroup analysis, and I usually like to look into these because they did a pre-planned subgroup analysis in patients aged 65 and older, and the results are very, very encouraging. CR rates in those group of patients, and it's not few. We have 109 patients. The CR rates is 75, and overall response rate was 88, and the median EFS was 21 compared to 2.5 months in the standard of care, which is actually better than the whole cohort, but you should take that with a grain of salt. All what it tells us that in older patients, Axicel actually was very effective. Okay, we'll come to tolerance in older patients somewhat so in the next few slides. And then few months later, actually a few months back, a famous publication got us all excited when the survival data came out of the use of Axicel in the second line setting. The ZUMA-7, and after a median follow-up of 47 months, showed that overall survival benefit, and there was 27% reduction in the risk of death in the Axicel over the standard of care arm, despite, and that's what blows my mind, excuse my language, that 57% of the patients in the standard arm actually got subsequent CAR-T and still got, an overall survival benefit. Okay. So, fun facts. In ZUMA-7, there was a subsequent analysis by Fred Luke and his group in Moffitt, and looking at the CD19 expression and how it impacted the efficacy of axi-cel. And the way they did it, actually, they used something called the H-score. The H-score is basically they put all the expression, CD19 expression, and then they get a median, and anything above the median is considered high expression. Anything below the median is low expression. Both, high and low CD19 expression patients responded equally. However, you can see that the outcome with the high CD19 expression is, and when it comes to event-free survival, is better. So, another fun fact, what about how did the metabolic tumor volume affect the results of ZUMA-7? And this comes up all the time when we discuss patients. So tumor burden is assessed in so many ways. You can use it, you can assess it. The cheap man test is LDH. I don't think it reflects the tumor burden. However, in this trial, they looked at all kinds of tumor burden surrogates, LDH, and something called SPD, which is sum of diameters, and an MTV, which is a slightly more complex way of looking at the tumor metabolic activity, the MTV, but it is done through a software. So again, both those with high MTV and low MTV responded better with axi-cel as opposed to standard of care. However, those with high MTV did slightly worse and had definitely more grade 3 CRS and ICANS. Okay, fun fact number 3, does the line of therapy impact outcomes with axi-cel? So if we use it second line versus third line, it's not a healthy exercise that I'm doing here. It's non-scientific, actually trying to compare the second and third line from the same cohort. However, because there was a significant number on the standard of care arm who actually got CAR-T, subsequent CAR-T, and that was 57% of the patients, 75% of the 57% got axi-cel, and the 25% got other products. You can clearly see the CR rates and the PFS rates. There is a big difference. However, there are so many confounders in this such comparison. Okay. What about safety signals? There wasn't any new safety signal. I would say that the grade 3 CRS rates, grade 3 CRS rates in the ZUMA-7 is slightly less than the ZUMA-1. What about going back to the older patients who had a pre-planned subgroup analysis? They looked at the quality of life recovery, and it seems like axi-cel, especially by day 50, provides better quality of life recovery to the baseline prior to the CAR-T and or using standard of care therapy. Okay, how many time do you have? How much time?
We do have like 10 minutes.
Okay, so what about the second product in the second line setting? It was liso-cel. It also made it as an approved CAR-T in the second line setting for high risk diffuse large B-cell relapse from the TRANSFORM study. Actually, from the TRANSFORM study, the primary endpoint was EFS. Both at a medium follow-up, and again, all of the liso-cel trials have short follow-ups for the third line and the second line, a medium follow-up of 17 months. The median PFS, EFS, and duration of CR was not reached. Okay, just to be fair with liso-cel, we don't have it here in Saudi Arabia, but it seems like a very effective CAR-T. What about liso-cel and overall survival? Did not make it yet, but the follow-up is short. Numerically, it looks like it wants to separate, but we don't know. We'll just wait for further follow-up, but there was no overall survival benefit with liso-cel in the second line versus standard of care. Okay, just to bring your attention that liso-cel in the second line setting is also approved for transplant ineligible patients. Axi-cel is only approved for transplant eligible patients. We know about the Albabtain study. The trial, the results are out, but FDA did not approve it yet. But liso-cel has a label for a transplant ineligible patient based on the Transcend pilot study, phase 2 trial that showed an ORR of 80% and CR rates of 54. Median OS was not reached, and median follow-up, it was only 1 year, but that got them the approval for transplant ineligible in the second line setting. This is going to be specifically important when we discuss other treatment options in the second line setting. We'll see about that. Okay, what about toxicity with liso-cel in the Transform study? Liso-cel is a piece of cake when it comes to CRS and ICANS compared to Axi-cel. You can easily spot the difference, from a mile. That you just focus on the fifth line CRS. Grade 3 or more was less than 1%, and grade 3 or more ICANS was only 4%. That is not the same as Axi-cel, and there wasn't any grade 4 or 5 CRS or ICANS, which is the most feared side effects of CAR-Ts. Putting everything together in the second line setting, we have for diffuse large B cells, we haven't talked about TISA-cel. The Belinda study was a negative study, a phase 3 trial trying to do what liso and Axi-cel did, but there wasn't any EFS benefit with TISA-cel compared to standard of care in the second line setting, so it was not approved in the second line setting. Bear in mind, these CAR-Ts have cells on the end of them, the nomenclature, but they're structurally different. Okay, so Axi-cel has a different co-stimulatory domain, that, CD28, which is probably responsible for all of the ICANS and CRS that we're seeing. However, the 4-1BB CAR-Ts can give you, they call them the marathoners, okay? They may be memory cells, okay? So, in summary, Axi-cel is approved in the second line diffuse large B-cell for high-risk relapses or primary refractory disease, and in the third line setting, liso-cel is approved for transplant ineligible, transplant eligible, second line, and a third line setting, and TISA-cel is only approved in the third line setting. Okay, what other challenges that we have with CAR-T? CAR-T, with all of the hyped up, with CAR-T and the excitement that we're seeing with CAR-T, there is a dark side that we all encounter, which is in part logistic, other part complication-wise, and financial toxicity as well. Okay. So, what is one of the most feared challenges in CAR-T treatments is the immediate and early CAR-T toxicity, speaking about CRS and ICANS. So looking at the CRS and ICANS rates across the phase 3 trials, CRS is very common with Axi-cel. Grade 3 and 4 CRS is 12% in the ZUMA 1, and it's almost negligible with liso-cel when it comes to grade 3 or more CRS. ICANS is also, because of the construct itself, is more common with axi-cel and with higher grades, also happening in higher grades. Okay, we cannot really finish our talk about CAR-T without mentioning the new kid in the block and the real competitor for CAR-T, which is the bispecific antibodies, the CD20, CD3 bispecific antibodies. We have 2 of them approved in the third-line setting, epcoritamab and glofitamab, a few months ago. They're different in how they're administered, and some of them have fixed duration schedules. Others have continuous administration schedules. I don't think that mosunetuzumab will be approved for diffuse large B-cell, but odronextamab, we're just still waiting. Epcot and glofitamab are approved in the third-line setting, and they do have a different toxicity profile, but that's in and by itself another topic to compare, to actually try to sort out what kind of treatment for third-line diffuse large B-cell lymphoma. Okay, so this is my last slide. Currently, this is how I treat, relapsed refractory diffuse large B-cell. There is a huge shift to actually classify patients according to their CAR-T eligibility. When they relapse, if they relapse less than 12 months, then we've seen an overall EFS and overall survival data with axi-cel. So if they relapse less than 12 months, the answer is CAR-T therapy, axi-cel, namely axi-cel and liso-cel and not tisa-cel. If they relapse more than 12 months after initial therapy, and they're eligible for autologous stem cell transplant, then you take them through the classic pathway of trying to salvage them with more chemotherapy, and if they respond and exhibit chemosensitivity, then you take them to autologous stem cell transplant. Those who achieve only PR with salvage chemotherapy are a big debate now. Some of us take them to CAR-T, some they proceed to autologous stem cell transplant. What do we do if they relapse after CAR-T or after autologous? If they relapse after autologous, it's a fair game because it's third line, bispecifics versus CAR-T. If they relapse after CAR-T, I think in my opinion, we should go ahead with bispecifics, and then the subsequent therapies comes as a second line for bispecifics. With that, I conclude my talk. Again, thank you very much.